Sahit, அது play பண்ணு.
Good evening, all the faculty members. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on TNF 4G imaging series. The theme of the series is theory to practice with practical day-to-day case
Sahiti, I will tell that. Today
Okay.
and Revati madam is there. First Revati madam, I'll tell few words, then Revati madam welcome address, we will start.
Okay.
Okay.
I will hand over the session to Dr. Sampath Kumari ma'am.
No problem.
Okay.
No need for CV and all. Good evening to all. I welcome you all for the interesting this imaging science series. We should really appreciate Dr. Malati Prasad. She has taken a tremendous effort. I think for the past next 3 months also she is having the program ready. Today we have the theme as second trimester imaging sciences. We have the speakers Dr. Lalita, Dr. Deepthi, Dr. What is her name?
Dr. Bela Bhatt,
Dr. Devasnita, Dr. Bela Bhatt, and the panel by Dr. Malati, I think. See, so we are planning to release this as a book, if time permits, in the annual conference. Okay, we have as of now 180 registrations. We have really we should put on hands to Dr. Malati. Malati, good work.
Yes, madam. Thank you.
So all the best for this webinar.
We're bringing in stalwart speakers from all over India. So our people should be benefited because of that. Otherwise, it becomes difficult. So all across the country, we'll be bringing in speakers, madam.
So all fetal medicines are here. This we are doing every month, third Saturday, 5 to 7. You do a good job, Malti. Continue it. We will try to make it as a book as possible.
Okay, madam.
Thank you. The mic to Dr. Revati madam for a few minutes.
Okay.
Good evening, all. It's indeed a great pleasure. No CV. Okay. It's indeed a great pleasure to welcome you all here. I am very happy that there are more than 180 registrations. And see, the scan part, especially the antenatal imaging techniques, coming to your doorstep is really a great thing. So you are able to learn and also discuss all your doubts with the expert through this webinar. And that's the reason why more and more are joining here. And TNFOG is proud to have Malati as a representative to do this very, very important program. Congratulations, Malati. And
Thank you, madam.
I welcome one and all. Thank you very much.
Radhika, no, sorry
Thank
for
you,
the
ma'am.
delay. We are on time.
Okay, ma'am.
You can start the first session. Madam has told, no?
Okay, ma'am. So we'll let us start
the
Tamil
session.
திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Lamp lighting. Moving on to the main program. So Dr. S. Chitra Madam, I am requested to
Madam, she can join.
She's joined.
No, she's not joined, madam. We can go ahead and start the session. She'll say she'll join after half an hour.
Okay, ma'am.
You can introduce the speaker, the first speaker.
Lalita. So Dr. Lalita is our speaker today. I requested to start her talk. Dr. Lalita has done MD-OG and MRC-OG. She has done a fellowship in maternal fetal medicine, and she is the associate professor, OG consultant fetal medicine at PSG hospitals. She's a member of ISUOG, RCOG.
I think
I should add that Dr. Lalita is a fantastic teacher, extremely talented person, and we're extremely proud to have you, madam. Thank you very much for agreeing to come in our webinar.
Thank you so much for the word.
Thank you. Thank
Share the screen.
Yes, ma'am. Please.
Yes, Lalita.
Is my screen visible, madam?
Yes, Lalita,
Yes,
you
ma'am.
can proceed.
Yes. So at the outset, I would like to thank TNFOG, Dr. Revati ma'am, Dr. Sampath Kumari ma'am for giving me this opportunity, and to Dr. Malati for inviting me to give this talk. Today, I'm the opening batsman for the day. So my talk will be on second trimester imaging, a stepwise protocol. I'm going to keep it very simple. So the objectives of this talk are to make one realize after the talk ends. So you should realize what are the normal appearances of different various organs in the fetus in the mid-trimester, and to be able to distinguish between normal and abnormal. So as long as you know what is normal, we will be able to see what is abnormal, and to develop one's own customized checklist or a methodology for fetal examination. 1 minute. Yes. So there are many guidelines which have been published regarding the performance of the mid-trimester anomaly scan. The latest being the ISWOG guideline, which was released in 2022. We have the ISWOG basic training also, which publicizes the 20+2 plane approach to the mid-trimester scan. And we have Dr. Suresh and team who have published the Rule of 3 protocol way back in 2014, and other society guidelines like the Canadian guidelines also give us some insight onto how to go about doing the scan. So today's talk will mostly revolve around this ISWOG guideline of last year. So prior to starting the scan, I would like to impress upon everyone the importance of history taking. So in medicine or surgery or pediatrics, we always impress upon the importance of taking history. In fetal medicine or in imaging also, history plays a very important role. So we have to take a complete history. We review the referral letter, what did the obstetrician or the referring doctor want from us, and elicit whatever the patient can tell us. From the present pregnancy history to the previous pregnancy complications or any other histories, any medical history for which she is on any medications, any other undisclosed information that you might get, which the obstetrician might not also have got, which the patient might tell you on repeated asking. So, and you need to document it. It might not be the softwares that are denoted here or Sonocare and Astrea. If you don't have any software, it is still pertinent that you note it down on a paper and attach it to your Form F. And browse through her previous ultrasound reports, lab reports, prescriptions, any discharge summaries, and then move on to your scan. So the scan itself starts with an overview. Like we are the fetal physicians, like how a pediatrician would do a complete head-to-toe examination of the baby, we would like to do a complete examination of the fetus. So before that, we like to do a survey of the fetus in utero. So you have to ascertain the fetal orientation, whether the head is up or down, the number of babies. Sometimes the first trimester scan would have given a singleton, and in second trimester, we would find another baby, right? So the number has to be re-established at your scan, the lie of the baby, whether the head is down or up, the presence or absence of the heartbeat, and the location of the placenta, the attachment of the umbilical cord, and the amniotic fluid. So this is a small video on how we go about doing the assessment. So I did not want to record on a patient, so I did on a mannequin. So we do a overall assessment on how the baby is lying on the maternal, inside the maternal uterus. So the image will show you this. So here, as we browse through, we see the placenta as posterior, the fetal head is down. Okay, the head is down. And on rotating, here we see the spine on the maternal left. Okay, the spine is on the maternal left. So indeed, this baby is lying with the head down, maternal left. So the baby's left side is down. So this is very important in establishing the normal situs of this baby. Okay, so as we move this video, we see that the heart and the stomach are on the same side, and it happens to be the left side of the baby. Okay, so you can actually imagine the baby, when you're imagining the baby outside the abdomen, the baby, how it's lying. So as we showed here, the baby is lying to the back to the maternal left, and the left side of the baby is down. And we establish the situs here by establishing the laterality of the fetus. So some people, when you start with, we can have a Barbie doll or any rag doll. You place it next to the maternal abdomen in the orientation that you've imaged now, and then you can establish the fetal laterality. So as all of us are aware, so before we start off, everybody knows how to measure the fetus. The biometry is something which all of us are familiar with. Okay, so we should ascertain if the LMP is reliable, or look at the first trimester ultrasound to see if the scan is correlating with the established gestational age. Otherwise, you need to correct the dates according to the first trimester ultrasound. The parameters which are regularly measured, the mandatory requirements are the biparietal diameter, the head circumference, abdominal circumference, femur length, and transcerebellar diameter. And we normally report them with percentiles. So if this patient was around 20 weeks, BPD corresponds to 69 centile for the gestation. So, and whether we use a Hadlock chart or the Mediscan chart has also to be mentioned in the report. So when do we do extended biometry? So whenever we suspect short long bones, if you feel the femur falls short, then you have to go back and measure all the long bones on both sides. And you go and measure the foot length also to derive the femur-foot ratio. And it's good practice to measure lateral ventricles in all the imaging, all the second trimester scans. It is good practice to measure the lateral ventricles and the renal pelvis in the axial view. So I again reiterate, renal pelvis has to be measured in the axial view. And special biometry is recommended only in terms of certain abnormalities. For example, if there is a cardiomegaly, we would measure the cardiac circumference and derive the cardiothoracic ratio. Or if there is a diaphragmatic hernia pushing with a mediastinal shift, compressing one lung, then we would like to measure the lung area to give a lung head ratio. So these are all specialized measurements which is not required in all patients. So any measurement that you're giving, you can even measure the fetal ear, the fetal nose, anything, but it should be according to the nomograms, and you should give a reference value. The reference range that you've mentioned also has to be mentioned in your report. And the measurement as such depends on the needs of the patient. So if the long bones are normal, why would you waste your time in measuring all the long bones on all the sides? Okay. And what is the referring clinician asking you for? So your report has to answer that question, and it all boils down to the expertise of the operator. So if I'm not confident of measuring the fetal lung, I wouldn't go and venture into it. So these are the normal planes that we take, the BPD, head C, the abdominal circumference, and the femur. So to stick to time, I would not be emphasizing on the landmarks of each plane now. So if there is time, we can look at it as the last slide. So as I told you, we are fetal physicians. We would like to examine the baby from head to foot. Okay, so this is the fetal head. So we are imaging the fetus from the fetal head. So the fetal head has to be imaged in 3 planes. All the 3 are axial planes. So the transventricular is the superiormost plane. The plane A is transventricular, and plane C is transthalamic, which is parallel to transventricular plane. And the transcerebellar is an oblique plane which covers the cerebellum and the posterior fossa. So all these 3 planes have to be imaged. So when you see the fetal head, what are the structures that you would like to see? So we would like to see the intactness of the calvarium. So the calvarial ossification has to be complete. And the shape of the head has to be oval. And because we have certain abnormal shaped skulls, you have strawberry skulls, you have lemon shaped skull. So all that has to be ruled out. And going to the intracranial contents, we first look at the scavum septum pellucidum. So it is a rectangular hypoechoic or an empty box which is seen close to the anterior end of the head, and it interferes or interrupts the midline forks. Okay, so we have to ensure that there is no midline inside the CSP. If you see a line dividing the CSP, then you're not imaging the CSP. It is indeed the phoneal walls of the lateral ventricles. So you have to have a box which is interrupting the midline forks and the intactness of the midline forks without any other interruption. And we look at the thalami on both sides of the midline. And here you can measure the BPD in the transventricular or the transthalamic plane. ISWOG and me as such in person, we would like to measure the BPD in the transventricular plane. I will tell you why later. And in the transventricular plane, you look at the ventricular atrium with the glomus of the choroid plexus snugly fitting in, it's not dangling, it's snugly fitting into the lateral ventricle. And down below, this is the oblique axial plane where we are looking at the posterior fossa. The contents of the posterior fossa are the cerebellum, which is dumbbell shaped. So any abnormal shape also has to be mentioned. You have a dumbbell shaped cerebellum. This is the cisterna magna and the nuchal fold. Either eyeballing would suffice, or you can even measure the cisterna magna and the nuchal fold. Okay. In all planes, in all the 3 planes in the fetal head, one important landmark that has to be mentioned is the CSP. So in all the 3 planes, you have to document the presence of the CSP. So moving down to the, this is the fetal head. So you've measured the you've imaged the fetal head. Then immediately you turn your probe, you can see the fetal face. Okay, so this is the fetal face. You can look at the axial part of the fetal face that is imaged in the topmost image where you're seeing both the orbits with the lens and the nose. So this is the orbital image. And then if you rotate your probe 90 degrees, you're going to see the sagittal view of the fetal face, the mid-sagittal facial profile. Here you look at the nasal bone, the frontal eminence, if there is any bossing or if there is any sloping forehead, the intactness of the palate and the mandible. So all these also have to be looked at in the intactness of the mid-sagittal facial profile. And when we look at the coronal view, so you looked at the axial view, you looked at the mid-sagittal plane, and you are cutting across the coronal view. Here you look at the fetal nose and the intactness of the lips. So the intactness of the lips rules out cleft lip here. And going below in a layer posterior to the nose and lips is your premaxillary triangle. The premaxillary triangle is formed, the apex is formed by the nasal bones and the base is formed by the premaxilla. So in cases with unossified or absent nasal bone, your apex will be absent. So the triangle is incomplete. If there is any interruption in the base of the triangle, then you suspect some problem with the hard palate. So coming down the baby, so you've imaged the head, the face, and then you're coming to the fetal neck. Here you can image just you don't have any particular measurement. You are looking at the trachea and the axial planes. There are no other masses, and you can even image it in the sagittal plane. The most important part. So from here and then you come to the fetal spine. Okay. The fetal spine, again, any organ in the fetus, when you see, it has to be imaged in 3 planes. One is the sagittal, one is the axial, and one is the coronal plane. So all 3 planes have to be seen. Only the sagittal plane is not enough. Okay, so the sagittal spine gives a typical tram track appearance with an intact skin covering it. And when you rotate your probe, from here, when you rotate your probe, you can see the, so from this plane, you go to this plane, you can see the coronal plane. Here, you can see the ossification centers and the normal width of the spinal canal. The axial plane in the spine is a sweep rather than a plane. So in the sweep, you sweep from the cervical to the sacral vertebra. And in every plane, you should look at 3 ossification centers of the spine: the vertebral body and the 2 lateral processes forming a triangle. So the intactness has to be imaged. So here we see this video. Here, this is the sagittal plane, and you rotate your probe, and I'm moving from the thoracic to the sacral, and I'm able to see the, you want me to stop here? Then I'm able to see the 3 ossification centers. This is the level of L1 moving up. This is the stomach, the heart. From the cervix, you move down. So you are seeing the triangle, which is the relationship of the 3 processes are maintained. And then you can come back and look at the coronal view also in this plane. So moving down, so after completing the head, face, neck, and the spine, we move down to look at the thorax. This thoracic cavity houses the most important and the most challenging organ that we all face, that's the heart. So here on eyeballing, when you see the fetal heart, it should occupy 1/3 of the thoracic cavity. For example, you should be able to place 3 hearts, similar sized hearts inside the thoracic cavity. Then it occupies 1/3 of the thoracic cavity, and the apex is slightly tilted with an angle of around 45 degrees from the midline, and the 2 lungs with normal echogenicity are seen. And obviously, we look at the heart beating also. So moving down to imaging of the heart. So this is how we image the heart. The imaging of the heart or fetal echocardiography starts from the abdominal view. Abdominal view to ascertain the laterality and the presence of the fetal stomach to the left. And we move up. Plane 2 is the level of the forechamber. Plane 3 is the level of left ventricular outflow tract. And moving up the baby, plane 4 is the right ventricular outflow tract or the 3-vessel view. And the 5th plane will be your uppermost, most cranial plane or the 3-vessel trachea view. So we would not be dealing with a detailed fetal echo, but I would be dealing with all these planes. So this is the forechamber view. Here you see both the ventricles are similar in size and both the atria are similar in size. So comparing the atria, the right atrium has a smooth contour, whereas the contour of the left atrium is not smooth. It's interrupted with the insertion of the pulmonary veins. We normally see in this plane 2 pulmonary veins entering the left atrium, and behind the left atrium is the descending aorta. And when you image the ventricles, both the ventricles are approximately equal in size, and the right ventricle shows a little irregularity at its apex, which is the moderator band. And the apex of the heart is almost always formed by the left ventricle in a normal heart. And you should look at the differential insertion or the offset of the insertion of the atrioventricular valves. The tricuspid valve is located a little more apical as compared to the mitral valve. So all these have to be imaged, and you don't have to measure the axis every time you see the forechamber. Eyeballing would do. If you feel there is a deviation, then you can go and measure. So you should rule out presence of any other structural abnormalities, diaphragmatic hernia or masses in the lung, which is pushing the heart to one side of the mediastinum. So the other planes, the left ventricular outflow tract or the 5-chamber view, it's a little cranial to the 4-chamber view. And this is the right ventricular outflow tract. So when you're imaging the outflow tracts, the outflow tract which branches immediately after coming out is the pulmonary artery. suppose you see that or you feel that the left ventricular outflow tract branches immediately, then it is not the aorta. So the aorta has to arch and come back and form the left-sided aortic arch. So if the left ventricular outflow tract branches, then it is a case of transposition of great arteries. So moving up more cranially, you look at the three vessel trachea view, which is the main pulmonary artery forming the ductal arch and the aortic arch meeting forming the descending aorta, and you see the trachea here. So now the imaging of the thoracic cavity and the heart is complete. We move down the fetus, and this is the level of the fetal abdomen. Again, you have to look at the presence of the stomach in the left side, compare it to the heart, and in this plane also you can document the situs. Okay. Now, establishing the normal situs, I've been insisting from the survey part of it or the overview part of the scan to the heart to the abdomen, because it's important. Many a times dextrocardia or situs inversus totalis have been missed. So you do a sweep from up to down of the baby's abdomen. You look at any abnormal bowel echogenicities or dilatations. And incidentally, you can have a look at the gallbladder, but it's an optional view. And coming down to the baby, so you look at this point, you would be looking at the cord insertion. You should look at the intactness of the fetal abdomen at the level of the cord insertion. Imperative because you're ruling out omphalocele or gastroschisis. And when you put on color, you see two umbilical arteries running on both sides of the urinary bladder. So this it gives us the diagnosis of a normal three-vessel cord. So the imaging of the kidney also has to be done in three planes: the axial, the sagittal, and the coronal planes. And as I reiterated in the previous slides also, the measurement of the renal pelvis has to be done in the axial plane only, because we get lots of referrals as pelvic cases, whereas it has been measured in the coronal plane. It should not be done. And you can measure, sometimes eyeballing is enough, and many a times measurement is needed to rule out pelvic dilatation. So when you put on color in the coronal view, you image the renal arteries. So as the imaging of the baby is done from head to abdomen, then you go to the extremities. So when we image an extremity, you have to ensure that all the three segments of all the four limbs are present. So which is the basic requirement. So the arm should be there, the forearm should be there, the hand should be there on both sides. The same way the thigh, the leg, and the foot has to be imaged. So all three segments have to be imaged for their presence. And then you go in and look at the long bones for their presence, shape, and echogenicity. Don't have to measure if they are normal. And the normal orientation of the joints have to be seen, because in this image where the leg and foot are related at an angle of 90 degrees at the level of the ankle is important to rule out talipes. And most important thing when you are imaging the extremities is to look at the movements. So sometimes in our keenness to look at each organ, we forget to look at the baby as a whole. Sometimes the baby is having a fixed flexion deformity or a fixed extension deformity, and it's not flexing and extending the limbs, and it's not opening and closing the hands. So these also have to be imaged. So as we have completed screening of the fetus, we just go to the environment of the fetus. So the placenta. So the placental location has to be seen, whether here it is anterior because it's close to the probe and close to the bladder. This is an anterior placenta and this is a posterior placenta. And it is good practice to measure the lower edge of the placenta to the internal os to rule out low-lying placentas. If indeed you feel it is low, you have to reassess it at the growth scan. And you have to look at the retroplacental hypoechoic zone. especially in an era where we have lots of cesarean sections, lots of uterine surgeries. We've had placenta, accrete or adherent placenta, even in primigravidas with IVF. So it is imperative that you image the hypoechoic zone behind the placenta. Here you see that there is a loss of hypoechoic zone and increased vascularity, and there is a bulge. This is an adherent placenta. This screening has to be done in all patients. So looking at cord insertion, it is good practice to look at the cord insertion at the fetal end and the maternal end and the placental end. Here we are looking at the placental end. This is a central cord insertion. Sometimes if you don't have to each time mention whether it was central or peripheral or marginal, but if it's a velamentous insertion, you can mention it. And the number, as we saw in the imaging in the axial plane of the abdomen, and you can get a cut section of the cord looking at the typical Mickey Mouse sign, 1 vein and 2 arteries. And if it's absent, in this case, there is only 1 vein and 1 artery. This is a single umbilical artery. So moving on to the last scene and the most important part of the uterus, which is the cervix. You can image a cervix in the transabdominal or the transvaginal plane. But according to me, in the target scan alone, it is important or ideal to measure the cervix in the transvaginal plane and transvaginal mode, so that you get an accurate measurement. And many times we get short cervices or there is funneling, which is missed when there is a full bladder in a transabdominal plane. So it is imperative that you ask the patient to empty the bladder and image in a transvaginal scan the length from internal to the external os. Is my time done, ma'am?
You have few minutes more, ma'am.
Yeah, I'm just finishing. Last few slides.
Okay.
And the important part of it is reporting. You have your own checklist. You can have a common checklist as we have in the ISWAG or SOGC guideline or the SFM guideline, or you can tailor it according to your own wish and expertise, and you can change it every time. So if you report the head as normal, it means that all the planes have been imaged. So if the head is reported as normal, you take the responsibility that all the planes have been imaged. And the landmarks, as you all know, so I wouldn't take time. If there is time later, maybe we can talk about the landmarks. So these are my references. Again, I would like to thank Dr. Malati ma'am and TNFOG for the opportunity. Thank you, ma'am.
Ma'am, I think it was a fantastic talk, beautifully narrated, and you covered every aspect of the anomaly scan. Thank you very much for joining. I think that the question in the question answer box, why BPD in a transventricular plane?
Yeah, I wanted to tell it that time itself. So, when we take a BPD, you should be very sure that you're not including the posterior fossa. So, when you're coming down to the arrow sign, or when you're eager to get the arrow sign, you in unconsciously you will be including a part of the cerebellum, so which we don't want. So, when you're coming down, you unconsciously go and image a part of the cerebellum. So many times in our eagerness to measure the thalamus and the V sign, we would be looking at the cerebellum. So to avoid that, even ISWAG recommends measuring in the transventricular plane, where there's no role of a posterior fossa there. So it's the same.
This neck part of the mid-trimester scan, could you please show the slide? Do you have any slide on the neck?
Yes, ma'am. I think it's there. It is not mandatory, but still. So here, this is the axial cut of the neck, and you are seeing this is the trachea. And if you are so keen, you can even look at the thyroid gland in this plane. But then here, we are not looking at anything. We are not wasting time. We are just looking at the presence or absence of any cystic hygromas or any other masses, the fetal goiter, all that can be ruled out in this plane or in this plane.
How to diagnose imperforate anus is another question. I think it's too far-fetched. Do you want to take that?
We have to image the fetal anus. I wantedly did not include it. It is called the perianal muscular complex. We get it like a target sign or we call it a donut sign. where there is a hypoechoic ring and an echogenic rectal mucosa, which is seen in the center. When you go to the fetal perineum, when you move down the fetal pelvis, and when you go to the coronal imaging, so at this level, you will see just below the bladder, you will see this donut sign, which is the perineal muscular complex. If it's present, then you rule out low anorectal malformations or imperforatans.
Thank you. Thank you, Dr. Lalita. I think it was a fantastic talk. Welcome, Dr. Tamichelli, to chair the next session. You can take over, please. Dr. Tamichelli?
Yes, ma'am. Thank you, ma'am.
Yeah. Thank you. Tamichelli is a young TRIOGS member with a lot of enthusiasm and eagerness in participating. So I asked her this morning, immediately she said, okay, I will join. Thank you, Tamil.
Thank you, ma'am. Thank you. Thank you, Lalita ma'am, for the excellent presentation. I'd like to call upon our next speaker, Dr. Deepthi Jammi ma'am. She did her undergraduate and post-graduation from SRMC, and she had done her fellowship in advanced OB-GYN ultrasound and postdoctoral fellowship in fetal medicine from Mediscan. And she is now the director of Jammi Scans. And madam had got so many gold medals and awards. Over to you, ma'am.
Thank you so much. Thank you so much, Malati ma'am, and the entire Tamil Nadu Federation of OG Imaging Series. It's a wonderful opportunity to be a part of this seminar. A great initiative, Malati ma'am. Congratulations. So,
thank you.
Can I share my screen? Yeah. I hope my screen is visible, ma'am.
Yes.
Okay. So, the topic is vast, but I'll definitely try to do my level best to snugly fit in all the soft markers as much as possible. Greetings from Chennai and all over India. I know that plenty of participants are throughout India in this panel. So let's quickly run through case series scenarios. So when we think about second trimester soft markers, okay, these are the things which come into our so these are the questions which come to our mind, right? So what happens when you have an echogenic bowel? What happens when you have a nasal bone which is unossified? Short, long bones, ventriculomegaly, all these things definitely will definitely have a spark on our mind when we see it. So then, why do we have to know? The first thing, as Dr. Lalita ma'am has already given, we know for sure that yes, definitely all these are very important because the incidence of anomalies are definitely increasing because of the advancement in technology, the machines, the targeted imaging, what we are doing, and also the inversion of pyramid of care. Apart from that, why do we need to do? One is to prognosticate the fetus. Two, for decision making, to involve the multidisciplinary team, and also to provide enough counseling, even if required, for pre-pregnancy counseling. And versus early versus late, yes, definitely. Nowadays, we've started to screen a lot of fetuses for an early target scan versus obviously our normal routine 20 to 24 week scan as well. And it is definitely operator dependent. And also the restricting factors would be maternal BMI or even multiple pregnancies. Having said all this, beautifully checked down checklist, which Dr. Lalita has already told us, I think we should have that in mind as well. Now, let me show you 5 golden rules, which we are going to follow for each and every soft marker. Check the image, measurement. First, once you identify a soft marker, check if it's isolated or associated with other anomalies. 3, check the first trimester screening report or the second trimester screening report if she has. 4, check the maternal or the paternal risk factors, if any. And 5th, involve a multidisciplinary team if it's required. That is a part of the pediatrician, genetic team, and a fetal medicine specialist. And watch out for these green tick and the red mask. I think we will start with the earliest one, which is a common one, which we all see in our day-to-day practice, an easy one to deal with. 25-year-old, primary gravida, marriage since 1 year with 20 weeks. You can obviously see in that the first thing, what we will see, an echogenic foci in the left ventricle. Still, the first question what we will have in our mind, shall we reassure the couple? 2, or shall we refer them for a detailed fetal echo? 3, do we repeat the second trimester screening even though the FTS is done? 4, or shall we offer them termination? I would not be surprised because even now we keep seeing patients with reports coming to us for options of termination for an echogenic foci, even now, even till this date. So what should we do the next time when we get an echogenic foci? The first thing we need to do, yes, is it as bright as the surrounding bone? Is it less than 5 to 6 millimeter? what it is. It's very important for us to know what it is so that we can convey this to the patient so that their stress or tension or the anxiety is reduced. It's because of the calcification deposits on the papillary muscles in our cardiac muscles, in the fetal cardiac muscles. So obviously there is ethnic variation. It's more commonly seen in the Asian and the Middle East population, and it's more so seen during the targeted scan, 18 to 24 week scan. And as I told you, remember the 5 rules. Once you identify an anomaly, the first thing what you need to do is check on the other markers. If it's not there, to see whether it's any associated anomalies or not. If it's isolated, the first thing what you will do, check on the first trimester screening. If it's low risk, then you reassure the couple that it's an innocuous finding and does not affect the function of the heart. But if it is associated with other anomalies, obviously you need to have a detailed level 2 ultrasound. And if it has other soft markers associated, you do give them the option of invasive testing depending on which anomaly is associated with this. And if it is multiple, even though if it's rare, if it's multiple or closer to the interventricular septum, you do have to follow up for the size, increase in size, so that you do rule out other neurofibromas or tuberous sclerosis. It's extremely rare. So this is not going to be a common finding, but these two are, yes. So obviously, once, remember the 5 golden rules, apply those 5 golden rules and go forward. This is the most easiest thing, right? So the echogenic foci. But let's come to the few things which are little difficult or challenging to handle. Obviously, over here in the transventricular plane, you can see small, tiny anechoic cyst, isn't it, among the choroid plexus. So obviously, a diagnosis is not very difficult. We know that the plane captured here is transventricular plane, and these are tiny choroid plexus cysts. At this point of time, what more information would you expect, and what will be the next step that you will take it forward? So let's apply the 5 golden rules in this also. The first rule. Here, let's see this. She is a primigravida. FT is not done. She's 21 weeks and she had bilateral choroid plexuses versus a 32-year-old primigravida. She was referred for a second opinion at 28 weeks of bilateral CP cyst. Would you management differ in these 2 fetuses? Then what does the question occur? Then next again, will you reassure both the couple or would you offer them amniocentesis even if it's isolated? 3, no procedure, no amniocentesis. Most of them will remain regressing, or again, do you offer termination? So these are the 4 things that should quickly run through your mind, right? So cancel off these 2. Cancel the option of termination. Definitely no for a choroid plexus cyst. Can we reassure the couple? Yes. Yes, definitely, as long as rest of the structures are structurally normal and you don't have associated anomalies. Definitely, amniocentesis is not required when it is isolated. So obviously, now let's run through the checklist for CP cyst. How? Already we saw how we are going to image. 2, yes, again, it is 1 to 2% in a normal population, and CP cyst more so common in trisomy 18 than 21. And the likelihood ratio is absolutely not more than the routine test. As long as it's an isolated marker, no other associated anomalies, your first trimester screen is negative, you can definitely reassure them. So remember the checklist, the 5 golden rules. The minute you see a soft marker, apply these 5 golden rules. And also, nowadays, we have the option of fetal MRI. As in the city of Chennai, we do have the option of fetal MRI. So would you offer fetal MRI for all of them? Now let's see for which patients we offer fetal MRI. So I told you, isolated, yes. Screen negative, yes. Majority of them regress in the 3rd trimester and absolutely neural development outcome is normal. Whereas when it's associated with other anomalies, when it's a screen positive for trisomy 13 or 18 with low HCG and PAPA, definitely this warrants an amniocentesis. So the cutoff is clear. Follow the 5 rules and then make sure that whether you see it as isolated or associated. Then when do you offer MRI? Can you see these huge cysts? This was a patient came to me probably 1 or 2 years ago. Huge, literally huge CP cyst. Even though they were CP cysts, they were really huge, close to 2 centimeters. Obviously, we would be worried about the pressure effect changes. Yes, we did offer an MRI. MRI also showed us and confirmed that it was CP cyst. We followed up, nicely regressed. The baby is absolutely fine now, close to 2 years of age. So all of them, they almost partially regressed by 34 weeks and the baby is must be around 6 to 9 months now. So all these 3 fetuses were perfectly hale and healthy. So remember this checklist again: isolated, associated, and large CP cyst. And as long as it's isolated, definitely you can reassure them. Let it be for the echogenic foci or the CP cyst, reassure them. And if it is associated with anomalies, make sure that you talk to them and counsel them for an invasive testing. And very large CP cyst, if you're concerned about pressure effect changes, early second or late third trimesters, you can definitely offer an MRI. Okay, apart from this, now coming to the little more challenging case scenarios, mild ventricular megaly. It's not as easy as your other two, isn't it? So this patient is a second gravida, previous LSCS, healthy-year-old, 21-year-old. This plane is around the transventricular plane. Obviously, we know that the ventricles are slightly on the higher side, which is about 10 millimeter. Here, again, it is around 10 to 12 millimeter, and moderate is around 12 to 15, and severe is more than 15. Nowadays, we don't differ between mild, moderate, and severe. Obviously, mild is around 10 to 12, and above 15 is around severe. So how do you measure? It's inner to inner wall, perfectly on the transventricular plane, because the type of measurement, zoom the image and measure from inner to inner. That is extremely important, because we still find fetuses for second opinion where even the lower part of the brain or even closer to the skull is measured and wrongly reported as ventricular megaly. So the plane which you use, the method by which you use is very, very crucial. Here, of course, you can definitely see a severe ventricular megaly or closer to a hydrocephalus in a term gestation, almost close to 27, 28 weeks. And this fetus is a 31, 32 weeker. Then how will you probably counsel these couple? Discuss about the neurodevelopment outcome, involve a pediatrician, offer an amniocentesis depending on whether they are in the phase, in the targeted phase, or option for termination. So now, again, let's apply the 3 golden rules. Why are we concerned about mild ventricular megaly? Here, since it's a soft marker, we are going to talk only about mild ventricular megaly. Most of them, when it's around 9 or 10 millimeter, do regress as the baby progresses, whereas we are more concerned about trisomy 21. So obviously, when there is a trisomy 21 pattern, we need to make sure that, again, go and check if your first trimester screen is screen negative. That's very, very important. Once your screen is negative and the rest of the fetus is structurally normal, then you sit and talk to the patient on about the neurodevelopment outcome. Obviously, apart from the 5 golden rules which we do, it makes a huge difference to talk to them about amniocentesis. Nowadays, we do offer chromosomal microarray as a part of routine screening, apart from a karyotype of a QF-PCR. Follow-up scan is very essential within 2 to 4 weeks of time. Maternal torch, if you have other findings, and fetal MRI is only indicated probably after the late second or early trimester. So remember, isolated within 10 to 12 millimeters, rest of the fetus is normal. Definitely with a screen negative, you can offer an amnio, but when everything else is normal, reassure them that most of them will settle down. And the risk of abnormality, yes, that is a wide range between 2 to 12%. That's the reason why we offer them an amniocentesis or a maternal torch. If it is associated with other anomalies, or if you find it secondary to other infections or hemorrhage, there's high possibility of a chromosomal abnormality or a genetic disorders. So yes, it's not that easy to counsel. I definitely agree, but the differentiation and application of this 10 to 15% rule, I think this is very easy to remember. That's how I do remember that 10 to 15% increased pickup rate is there in chromosomal microarray when we offer it. 10%, 10 to 11% increase in additional findings when you offer an MRI later in gestation. Yes, that could be a possibility of mild increase in ventricular megaly size from mild to moderate, and 10 to 15% of neurodevelopmental outcome when everything else is normal. Around 90% of the babies do really well, and hardly only 8 to 10% of them might show up a mild neurodevelopmental outcome delay. So I think this checklist will definitely be useful when you identify a baby with mild ventricular megaly as a soft marker. And over here, going on to the next thing, which is going to be an echogenic bowel. And where do you see the echogenic bowel? Here, there's a bladder over here in the coronal section where Latham ma'am is already given. Between the stomach and the bladder is where you identify the small bowel. And what happens when you see an echogenic small bowel? Obviously, here's a preemie with echogenic small bowel. The probable diagnosis, yes, before even ruling out to an abnormality, first, check for fetal growth restriction. Number 2, associated anomalies. Number 3, ask for bleeding in the first trimester. Plenty of times we've had history of bleeding patients with echogenic bowel. Could be a transient finding. So here, again, would you think about termination? Definitely not. rule out your FTA screen, reassure the couple, rest of the fetus is normal, follow them up at 6 weeks to rule out intestinal obstruction. Cystic fibrosis counseling in India is very rare unless and until they are carrier genes or they've had a previous baby terminated or genetically tested. Obviously, first, the diagnosis is very important. The likelihood ratio here goes slightly higher. It's around 3. So you need to be very careful when you counsel them. As long as it's an isolated finding, gradings are not usually recommended at night now. As long as if it's brighter than the bone, that's more than enough. Yes, T21, why do we have trisomy 21 babies having, say, echogenic bowel? Is that because of dehydration of the meconium? There could be a mechanical or a functional bowel obstruction. That's why a trisomy 21 fetus could have an echogenic bowel. And when non-chromosomal, yes, we could probably have a cystic fibrosis. That's because of your pancreatic enzyme secretion. In FGR fetuses, that could be because of a secondary hemodynamic redistribution. So apart from all this, again, a protocol-based approach. The same thing what we usually see, rule out the growth, other anomalies, first trimester bleed, check the first trimester screening report, do a maternal torch, isolate it, reassure them, follow up after 6 to 8 weeks. Incidence is very less of cystic fibrosis in our population. Involve a pediatric surgeon if you identify a dilated bowel loop, and definitely tertiary care if you are suspecting an intestinal obstruction and not as a soft marker. We have now probably come down to the fag end of our soft markers. And when we come to the fag end of the soft markers, again, we have the last two, which is the renal pelvic stasis and the unossified nasal bone, apart from URSA. Yes, obviously, you will be able to see renal pelvic stasis in this picture. Here, if it is a UTD1 classification at 23 weeks of gestation, here we do see that the renal pelvis is dilated. Okay, so the next question again comes. Do we follow up? Do we reassure them? Or do we alarm? Again, what we need to do is an AP diameter measurement, check out the other abnormalities in the fetus, follow our rules, and then involve a pediatric urologist in our counseling. That's extremely crucial if it is going beyond 10 millimeter in the growth scan. But if it is around 4 millimeter, and if you are considering is as a soft marker, then make sure that you talk to the patient about the first trimester screening report and not into your counseling for hydronephrosis. And when are you worried about it? Only when it goes beyond 10 millimeter. And what do you have to do if it is less than around 4 to 5 millimeter or any, make sure that it's around probably 3 or 4 millimeter. Check your first trimester screening report. Rest of the baby is normal, then reassure them and follow it up. Here is a case of full-fledged severe hydronephrosis. So you do not worry about these hydronephrotic babies as a soft marker. So your soft marker falls more in favor of a mild or a minimal renal pelvic stasis. So the same findings again, level 2 ultrasound, if it's associated with anomalies, then you counsel them for an amniocentesis. And if it is persistent, involve a pediatric urologist. So yes, again, single umbilical artery, I could talk about soft markers literally for 2 hours, but I'm trying to cover up as much as possible. We do come across single umbilical artery more common because we are screening these fetuses quite early also. Yes, again, perform a detailed level 2 ultrasound along with fetal echo if possible. Cervical, yes, interval growth scans are important with close surveillance if it is associated with other anomalies. If it is an isolated problem issue, it's not a big issue at all. Counsel them, reassure them. Yes, occult anomalies could be there, about 2 to 5%, but that's rare in a GIT tract anomaly. So do counsel them. You can definitely have a watch of the perianal muscular complex, which was discussed earlier. And if it's a single umbilical artery, most of them do really, really well. Even the growth is fine. URSA is one of the new marker which has come up now because earlier days, like 10 years, 12 years back, we wouldn't really worried about URSA. But for the past decade, we are looking out at it because its likelihood ratio is close to that of 3.4, which is similar to your echogenic small bowel. What are you worried about? Again, first trimester screening, rest of the baby normal, reassess the risk of likelihood ratio, then offer them invasive if at all you have an associated anomaly. Even if it's an isolated URSA and your first trimester screen is negative and your redone risk with your likelihood ratio as per the software is low risk, then you can definitely reassure them. Obviously, you can talk to them about NIPT or amniocentesis if they are really concerned. Last, but not the least, I'm going to take you through short long bones and the nasal bone. Obviously, here we are talking about short long bones where we are thinking more in the soft marker area. So if you think, before even you think about a soft marker, you need to rule out everything. You need to rule out the growth. You need to make sure that's a constitutionally small baby or to a short long bones. Only then, not all short long bones go into skeletal dysplasias. And also you can also remember that the femur to foot length ratio, it's in and around 1. And remember, check the maternal height and the paternal height. That also plays a huge role in screening. So obviously it's a short femur. Check for your screening report, and depending on the screening report and the rest of the other anomalies, you do counsel them. And last, we are coming to nasal bone. Nasal bone itself, I could talk about like with that for 1 hour, but then we are going to talk about nasal bone, these 3 dotted lines, which you can see over here. This is the same fetus, if you can see, it looks like present and this is absent, isn't it? This is the same confusion which we all of us end up in our day-to-day practice. Here, I'm going to show you 3 case scenarios. 12-weeker with an absent nasal bone. Her risk was, final risk of absent nasal bone was 1:4,084. You have the second case series who is a 11-weeker with absent nasal bone, and her risk, if you can see, is around 1:269. Third case, where she's a 36-year-old with an absent nasal bone, and her risk was 1:5. Now, we have 3 patients. All these 3 patients, let's think how we can manage. How will our counseling be different? The first case, 12-weeker, unossified nasal bone, we didn't do anything because the screen was negative. We called her back for a target scan, beautifully ossified nasal bone. The baby is absolutely normal now. Case 2, 11-weeker, she had an intermediate risk. We did an NIPT and the screen was negative. The baby is normal. Case 3, you remember, a 36-year-old, amnio was done. Her risk was 1:5. Her karyotype was normal. So not all unossified nasal bones are going to be Down syndrome. That's very, very important. I think that's one of the main things that I want to probably say is as a take home, because everyone, once we see an unossified nasal bone, we really get jittery. This, yes, as a second trimester marker, when you see it, you definitely have to have a detailed anomaly scan. Here you can see the babies with clenched hands and fists with a short depressed nasal bone. Then you can also see that this baby was a trisomy 21. So it's extremely crucial that you call them back to make sure that they are seen again in the nasal bone and make sure that they are offered. So overall, in our case series, I'm going to finish it off now. Most of the isolated unossified nasal bones did really, really well. If you can concentrate over here, most of the isolated unossified nasal bone in the second trimester had a normal karyotype, NIPT was screen negative, and absolutely normal. So after seeing this data over 5-year data, then we started reassuring most of the patients that isolated unossified nasal bone, do not worry. But early this year, we do come across surprises or shocks in our study that, yes, 20-weeker, absolutely normal fetus, only hypoplastic nasal bone, nothing else, previous normal child, her trisomy 21 risk was 1:3,352, and we did an amnio only for hypoplastic nasal bone, and that was detected Downs. So the take-home point I would say is, do not alarm the patient immediately. Go through the checklist, go through the protocol, remember the 5 golden rules, and then counsel them. Don't alarm them. Most of the time, isolated unossified nasal bone babies are going to be normal. Yes, very rarely you do end up with Down's babies. I'm not saying no, but you can definitely make sure that you counsel them at your list, at least avoiding a termination. I hope I have answered all these questions which we started off in the beginning of our lecture. What would you prefer over FTS over quadruple? Definitely FTS if possible, because the sensitivity of a first trimester screen is 85 to 90% and the quadruple screen is 75%. Reassure them if it's going to be isolated echogenic foci, single umbilical artery, choroid plexus cyst, as long as the rest of the fetus is normal. Routinely, a torch panel for echogenic bowel is not mandatory as long as the rest of the baby is perfectly normal. Yes, you could offer NIPT as a rule, as a protocol, if rest of the baby is normal in unossified nasal bones, and not all short long bones end up with skeletal dysplasias. Thank you so much, ma'am. And I'm again putting up my checklist for the 5 golden rules. I hope this information was useful to all of you, and I'll be glad to answer the questions if there are any. Thank you so much for the wonderful opportunity, Malati, ma'am.
Dr.
Thank you,
Deepti, I
ma'am.
think it was a very fantastic and very, very clear presentation.
Thank you.
You have one question in the chat box as
Yeah.
should you do combined test, double test in unossified nasal bone?
Sorry, combined test in a?
There's double test in an unossified nasal bone of
Yes,
12
definitely.
Yes,
Yeah,
there is no
there is
doubt on that.
absolutely. Yeah,
There is no
because
doubt.
the thing, what we need to do is, as long as you catch the patient as early as in the first trimester, you catch them there, because the sensitivity of a first trimester screen is highly accurate. It's around close to 90% when it's done well. Whereas the second trimester risk, you don't have the opportunity to include your nasal bone as a protocol in the second trimester. It's only going to be a quadruple screening with a screen positive of 75%. And the minute you have a screen report in the first trimester, you have a long time where you can actually talk to them, give them time to decide, and you have time to even take them up for procedure. So I think the rules will follow, and definitely first trimester screening does play a major role when you find an unossified nasal bone.
How to counsel and follow intermediate risk?
I know. Yes, we are not going to. Intermediate risk is a gray area. As much as it's a gray zone, it's a gray area even for the obstetricians and the fetal medicine consultant. But how I would see it is, if it's an intermediate risk, the first thing what you need to see is to go and see the a priori risk. Say, for example, intermediate risk is anywhere between 1:250 to 1:1000. And if your a priori risk, say for age risk, what I mean by a priori is age risk. Say a patient is having an age risk of 1:1500 and your final risk is 1:300, I'm concerned about it, because her risk is increased from 1500 to 1000 or 1:300. Whereas if her a priori risk was 1:400, say she was 35 years or 34 years, and her intermediate risk is only 1:400, I'm not really concerned, because her age risk was also the same. If your final risk is increasing from your a priori risk, then that patient needs to be counseled. You can offer them an early target scan, check on the structural anatomy of the baby. If structurally the fetus is normal, you can definitely offer them NIPT, non-invasive prenatal screening. If you identify any soft marker, recalculate the risk based on the LR ratio and offer them invasive if this is a structural anomaly, even for an intermediate risk.
Thank you. Over to the chairpersons. Chairpersons want to give any concluding remarks? Dr. Tamilchelvi, Dr. Chitra, are you there?
Yes,
Dr.
ma'am.
Chitra? Yeah.
Ma'am, we also have another question.
Yes.
23-year-old primary NT scan not done. Now 20 to 22 weeks. An anomaly scan shows a single umbilical artery, absent nasal bone, echogenic foci in LV, and choroid plexus cyst. How will proceed?
The first thing is, she's already 21, 22 weeks. So you don't have much time in hand to act. You need to call her for an invasive testing immediately. There's no concept of doing an NIPT here. We have had 23 weekers, 24 weekers done NIPT, showed high risk, and come to us for amnio at 24 weeks. It doesn't make sense for us to wait for 15 days for the NIPT report and with the structural soft marker shown in the scan. That's a direct indicator for an amniocentesis. Not more, much, you won't get much more for an amniocentesis. So call her immediately, do an amnio. If she is already on a 21, 22 weeker range, please get a Q of PCR or a FISH done in 48 hours. You don't even have to wait for a microarray here. Within 48 hours, you will get your Q of PCR report, and once you've ruled out trisomy 21, you will be really at least satisfied that you've done the best thing for the patient, and you can follow up the mother.
Yes, thank you. That was a perfectly decoded presentation, ma'am, on soft tissue markers. Thank you. Now I would like
Thank
to
you, Dr.
call upon...
Deepti. Thank you very much.
Thank you, ma'am. Thank you, Malti, ma'am.
Thanks so much.
Thank you, ma'am. I would like to now introduce our next speaker, Dr. Debasmita Mandal, madam, to talk on invasive testing, when to offer.
A very
Welcome,
good
Dr.
evening to
Debasmita.
everyone. Yeah, ma'am.
Welcome. Thank you very
Welcome,
much for
actually.
joining.
Yeah.
Debasmita is extremely academic, extremely knowledgeable, and I have no
Oh,
words.
no, ma'am,
I'm
nothing like
happy
that.
to
I'm
have
only
you.
learning, and we together learning. And you are doing a fantastic job by
Thank you.
actually amalgamating so much of learned gathered. I was not knowing this people, all doctors and all. I'm really happy to listen that soft marker and other things also. That was like brilliant, actually. Your webinar is going very brilliant. It is a really unique idea, actually, ma'am.
Okay.
Thanks for calling me in this
Yeah.
webinar. And
Thank
it's a great opportunity to be with you, as well as Bella madam, as well as other doctors, chairpersons, my respected chairpersons who are sitting beside me. And my topic is totally theoretical. I don't have the ultrasound images to show and all that thing. So my topic is about, but it is a very pertinent topic rather, I should think. That is the invasive testing when to offer. But I believe that whenever we are being offered something, then we have to think many things actually come into the mind. When you have to a lot to offer, we have a right to be selective. That is most important thing we need to realize. Then if we are offering something, there is some acceptance also. Offer and acceptance goes by together basically. Then how to offer, like if there is some complications or something, how to manage all these things. Then and offer whatever we are doing, many things, what are the elements also associated, those are many things. And the most important thing is about the timing, that is Shubh Muhurta. So it is all about the selection of right cases, how to manage in complications, what are the best timings, what are the prerequisites when we are offering actually. These are all things we need to take care of. Offer and acceptance, what I told, and what the guideline says. The whole presentation has been made according to the guidelines only. So prenatal diagnosis enables the diagnosis of a broad spectrum of chromosomal abnormalities, as well as many kind of single gene disorders, as well as many kind of infective pathologies, what we are suspecting in the ultrasound, but we are diagnosing by per se. So that is one of the wonderful things that we are doing for the invasive. And so when to offer arises from those things only. So enables us to decide about the mode of management of pregnancies. And the various invasive prenatal diagnostic tests are like amniocentesis, chorionic villi biopsy, cord blood sampling, and these all things. The learned people who are sitting here, doctors who are sitting there, already know all things about it. So amniocentesis referred to, I'm just giving you a small introduction about that. Amniocentesis refers to the transabdominal aspiration of amniotic fluid from uterine cavity. This procedure has been performed since 1970, and it is successfully improvised with the technique as well as with the indications as well as. And chorionic villi sampling can be performed transabdominally or transcervically according to the operator's experiences as well as preferences, as well as the placental locations. It is very important to collect the placental villi, that we all know. And it is the cord blood sampling actually is performed through the maternal abdomen, and it is usually performed after 18 weeks because at that moment of time you can see the cord insertions properly. And so the lumen of the cord is more visualized between 20 to 28 weeks. Though it is almost an obsoleted method, still we are practicing for some reasons. So if you are considering about the timing, it is about the amniocentesis should be performed at least 15 weeks after that only, because many reasons are there. Because extra-embryonic coelom, that is in the first trimester, actually it is almost cleared with the choriodecidual separation and everything, fusion, all things are, all confusions are actually vanished after the 15 weeks only. So naturally we are in the tendency for the less complications rates and many things. So there will be also reduced amount of amniotic fluid. So we are considering about this kind of gestational weeks to perform our things. Then early amniocentesis is associated with increased rates of miscarriage and other kind of other things. And there is a term called late amniocentesis that is very important. That is usually more than 34 weeks. I'm in a medical college setup. So in my private setup also, so I tend to get a lot of late anomalies and late problems actually, that I am bound to do the amniocentesis during the late period. That is usually more than 34 weeks or more than 28 weeks certain times in that way. But in certain circumstances, actually it is helping a lot. Because we are able to do microarray, we are able to do whole exome sequencing, so many things, other things. So it is actually deciding factor after the postnatal as well as even the late termination, which has been allowed by the Supreme Court recently. So chorionic villi biopsy is usually performed between this 11 to 13 weeks. And actually in my setup, I prefer usually 12 weeks to 3-4 days, because at that moment of time, we get the good chorionic villi amount as well as the procedure easy way and everything. And we can do a very good scan by transvaginal scan. We can see all the anatomy. We can see many things before the chorionic villi biopsy. So deciding factor is not much very confusing at that moment of time. So we can go ahead with this kind of things till the 13 plus 6 weeks. Even after at 14 weeks also people do, but I don't prefer at that moment of time. Maybe a chorionic villi getting much is not so good at that moment of time. And chordocentesis, that I have already told. So regarding the indication, if I go to the straight away, that is chromosomal studies that we know, advanced maternal age, and high risk for aneuploidy in the NIPT, as well as if I am getting something kind of fetal anomalies on ultrasound or any kind of soft markers like multiple soft markers, then we are actually thinking for any kind of invasive at that moment of time. Because the likelihood ratio for the soft marker is really, really increased at that moment of time. And the previous child with any kind of chromosomal abnormalities, malformations, any kind of parental chromosomal abnormalities that is leading to recurrent abortions, recurrent intrauterine deaths. So at that moment of time, even if the fetus is ultrasonologically normal, even if the anatomical normal, still we are going for the invasive test to decide out what is happening inside. So molecular diagnosis of single gene disorders like thalassemia, cystic fibrosis, muscular dystrophies, then spinal muscular atrophy, we tend to get lots of spinal muscular atrophy because autosomal recessive disorders, both the parents, they suffer. So are the carrier and the baby suffer. So naturally we have to go for a usually chorionic villi biopsy. We prefer at that moment of time because we actually get the diagnosed case. Not because of the chorionic villi, DNA amount is much better or something, but tend to get the diagnosed cases. So naturally we can, at the early weeks, we can approach that. Then congenital adrenal hyperplasia, hemophilias, any kind of von Willebrand factor deficiency, those and other monogenic diseases also. So diagnosis of glycogen storage diseases also, many kind of glycogen storage diseases we have diagnosed. Like mucopolysaccharides and Pompe disease, so many diseases has been diagnosed by this. And those actually, if we look into the factor in the glycogen storage disease, because we miss the ultrasound findings, because it happens in the late trimester or after the baby is born, usually you have tend to see all the anatomical problems or any kind of other problems or any kind of metabolic problems you tend to see. So naturally those postnatal suffering and the genetic test in the postnatal baby, then we get to the diagnosis. So prenatally we get usually previous diagnosed with the glycogen storage disease because we cannot able to diagnose in the recent pregnancy. So we have preferred the chorionic villi biopsy in those cases basically. I'll show you my list, what are the things we have done actually. So if you look into the chromosomal aberrations, it has been in the Kypros Nicolaides books and everybody has read about it. If the nuchal translucency, it is such a normal thing that we tend to the NT scan, we go for the thing. So it is the most commonest thing that we get for the invasive test in our ultrasound field basically, whether it is if it is not at the previous diagnosis basically. So if we look into the thing, if it is more or less than 95th centile, whereas the chromosomal defects is almost 0.2%, but if we look into the fetal death ratio and other things, it is almost 1.6%. But if it is more than 3.5 to 4.4 millimeter, so the chromosomal defects is coming to almost 21% increase and 2.7% of fetal death. So, and also 10% chances of major structural abnormality that we may not see during the first trimester. So naturally, we have to go for invasive to rule out what are the things are happening. And it again depends on now the NIPT and all things has been improved. I will go for the next slide, how to approach these cases also. So there are the diagnostic indications and the therapeutic indications. Already I have told about the chromosomal analysis, advance. The amniocentesis has got the same kind of indications only. They differ, many things we differ. Like if you want to establish a difference between the mosaicism, placental mosaicism or fetal mosaicism, amniocentesis is a much better test to go for this, because at that moment of time, the placenta is well developed to go for the things. So naturally, amniocentesis is taking the advantage from the chorionic villi biopsy in those kind of things. And the other things, whatever the indication I have told, these are only the same things. We can go for the amniocentesis because many times people don't approach the referred cases, don't approach during the first trimester only. So we get for the amniocentesis those things. And nowadays the indication of amniocentesis, maybe it is genetic testing or other things, RH isomination and other things has been written in the book regarding the fetal lung maturation, but we are no more going for those kind of indications. We are going for this all kinds of indication I have already mentioned. And diagnosis of fetal infection is one of the boon actually, I should tell, because the amniotic fluid usually developed by the placental as well as the chorionic membrane. It is contributed during the first trimester, and so we see the amniotic fluid is very normal. So when we are doing the ultrasound and we don't see at the kidneys or individually or anatomically, we are not going to see all these things. So we are thinking the bladder is normal, the amniotic fluid is normal, so everything is normal, maybe the kidneys are working actually. But what happened, the amniotic fluid is contributed by the kidneys, it is around 20 weeks. almost more than 18 weeks. So naturally, at that moment of time, if it is a kidney agenesis or renal agenesis, we tend to get those kind of things at that moment of time, if we are not looking at the first trimester scan properly. So even if the fetal infections, the fetal urine contribution is done by the fetal kidneys at that moment of time. So chorionic villi biopsy doesn't have any kind of role at that moment of time. Rather, we should go for amniocentesis to rule out any kind of infections if we are suspecting in the ultrasound, or we are getting in the maternal history, or in the lab test we are getting something that is getting us to go for this amniocentesis. So amniocentesis is taking advantage in this kind of cases also. So therapeutic role in hydramnios, it is a therapeutic role for the maternal discomfort. Every obstetrician will be very much comfortable with this, but many a times we tend to avoid kind of things because it may land up in the preterm labor as well. Then decompression of the amniocentesis in twin oligohydramnios, polyhydramnios sequence. So as it decreases the volume of the amniotic fluid, one of the sac, and naturally it reduces the pressure and improving the uteroplacental circulation ultimately. And even the amnio infusion in the oligohydramnios cases, we can go for. It is really dicey to tell whether the amnio infusion is going to improve the fetal outcome or not, but still we can try rather. And it is indicated for the fetal transfusion in the fetus having the severe hydramnios. So in that cases. So prerequisites, that is most important thing we do in our clinic is maternal history. That is very important. We detail obstetrics history of abortions, preterm labor, any medical disorders, because these are very important to rule out the genetic causes, definitely, how much it is related to other things, but also whether your procedure is going to be successful or not. So in that way, you can exclude the maternal age. If it is like 47 years, with the pregnancy they are coming with the IVF and with the 2 recurrent abortions, so whether to touch this patient or not, that is really dicey. What I am doing, whether I should go for NIPT in those cases rather, or I am going for the amniocentesis if nothing is there, only a one isolated marker, or I am not seeing anything, only a nasal bone absent, so whether I should go for amniocentesis or not. So these are the decisions from those good history we can delineate out actually. Then blood grouping iron stepping is very important because anti-D, any kind of procedure, invasive procedure we're going to do, it can create a feto-maternal hemorrhage and it can go for the dissemination. So we have to go for a 300 microgram only prophylactic if it is a negative one within the 72 hours, nothing like 150 or something, or my needle is going very spontaneous, so it will be reduced rate, reduce in dose, nothing like that. It is 300 microgram. Then maternal aneuploidy screening, infection screening, those are very important. Whether I'm going for amnio without any workup, that previous speaker has told about that, without any software calculations of the risk, as well as without amalgamating the software calculation as well as your serum screening, then we are going for the amniocentesis, then it is nothing actually. We have to calculate the risk from that only. And the good fetal ultrasound, that is going to logically go for the fetal viability, gestational age. Many a times amniocentesis patient has come for the indication and I have seen the fetus is already dead. The T21 risk was like 1:5 and all, but I saw the baby is dead. So the thing is, the fetal ultrasound doing is very important, seeing the viability, gestational age, number of the fetuses, placental location, amniotic volume, fetal anatomy survey, uterine cavity abnormalities, presence of fibroids. Those are very important because how you're going to put the needle, the fibroid is going to decide, not you or patient. So this is the way we have to know. The counseling of the couple is very necessary because what you are offering, they may not be ready with it also. And they may blame you on other sense. So that is why indication, risk, benefit, limitations, everything you have to go. So when to differ is more important, like we decide as a gynecologist when you're doing surgery, what not to do, when not to do the surgery. That is very important. Hepatitis B, HIV infections, if it is with a high titer at that moment of time, it should be totally abandon the procedure. That is very important because high titer can transmit the baby as well if you are going to injure the thing. So it should be deferred in HIV infected patients. But until the antiretroviral therapy, that has gone to a low titer. So at that moment of time, we can do if it is really, really necessary, but better to avoid. And decrease amniotic fluid, oligohydramnios, it is an indication, but many a times amnio infusion can be done. If it is so necessary, we can go for a amniocentesis. Oral anticoagulation therapy must be stopped 48 to 72 hours. Nowadays, in vitro fertilization patients are coming very day in, day out. So we have to know how to manage that. Then maternal complications, many kind of risk, fetal-maternal hemorrhage, isomination, risk of preterm labor, 2 to 3% of vaginal bleeding, post-procedure pain, though amniotic fluid embolism is very rare, but I have heard about that. then a hematoma of maternal skin, these things can happen. Then fetal complications, it's very important to explain the patients, though it is very less, but it happens. The risk of fetal loss is higher in women who are otherwise at high risk of miscarriage. That we have to know, that your history is going to help you out here. So this is very important. Then amniocentesis is almost 86%, almost free, and it is very free from any complications and very safe. Many kind of literature have shown that. The risk of fetal loss in case of multiple pregnancy is very higher, and it's about the chorionicity, how the placenta is implanted, everything. Amniotic fluid leakage, 1 to 2% it can happen. That has to be explained to the person, the woman who is going through the amniocentesis. But we have to tell them that spontaneous healing can happen, sealing can happen, and also we have to go for some progestational therapy if it is needed for the pregnancy support, though we don't give regularly. Then many kind of other fetal injuries, though it is rare, but if it is with a less experienced hand, it can happen. So invasives in the special condition, how we offer actually, like monochorionic diamniotic twins, dichorionic twins, and there is a term called late amniocentesis and amnio versus NIPT. If there is a confusion, how we actually lead to it. Then if I am going for the late amniocentesis, actually, which is the regular scenario in my hospital, in medical college. So I have went through certain kind of literature which has been published in the British Medical Journal. They have detected the late detected abnormalities like central nervous system, cardiovascular malformation, urogenital, many kind of malformation like SGA, recurrent growth retardation, increase NT, but they have suffered with many kinds of other things later. So certain kind of things have went through the late amniocentesis, like abnormal NIPT result also. Many a times we receive the patients like at 24 weeks, they don't have even the quadruple test, even the double marker test. So naturally the NIPT is the best at that moment of time. Taking a free cell DNA is much more better than quadruple screening, which has got a less sensitivity. It is almost like 60% sensitivity, and triple marker is totally obsoleted. So we have to consider the best tests which are going to lead for our amniocentesis result. It is either NIPT or the double marker high risk. It is very important to learn, because first trimester is the best window to see all kind of anomaly at that moment of time, direct anomaly or predicting anomalies later. So if the combined risk is going to affect, like it is less than the 1:50 or something, then we have to go for amniocentesis. That is very important. Though we have got many kind of laboratory value, like 1:250 you can take, 1:, this kind of things. But we have to see, we have to measure everything, whether it is complicating to the patients or also not. So that is very important, because every pregnancy is valuable for us and as well as the patient. That is very important. So another request is about the patient request. So patient request, many a times we have to obey, because many a times if we'll go for the thalassemia screening, maybe the lady who doesn't have the thalassemia and the husband has got, but still they have got a suspicion, maybe a thalassemia carrier, please diagnose. But it is not needed. But many a times patients request, if it is possible by your law at the state, then it is, we can go for. So the overall incidence of preterm birth, intrauterine demise after amniocentesis is very least actually. The literature is explained like this, but we have never faced those kind of things, except some kind of abortions. 69 fetuses, this study has concluded 69 fetuses with aneuploidy, that is 5.3%, 72 fetuses with pathogenic copy number variation they have got. The maximal diagnostic yield was almost 70%, was in the subgroup of the fetuses with abnormal diagnostic results, followed by abnormal NIPT results. So multiple abnormalities they have found almost 23.8%. The whole scenario was like this in the late amniocentesis group. So 35.4% could terminate because of this late amniocentesis results. So the recent study they have shown, there is a reported almost 3% rate after their amniocentesis in the the meta-analysis reported a pool loss of rate of 3.8% in the chorionic villi biopsy in the twins. It is talking about the monochorionic twins as well as the DADC twins, because there is no study could found out that individually they have taken the risk individually. So before performing an invasive procedure in multiple gastations, it is critically important that chorionicity and placentation should be explained properly and labeled. The fetus should be labeled properly, and the discordant CRL has to be labeled properly. Anomaly in any fetus, that has to be properly seen, and other same indications that we have gone through. We have went through the previous slides actually. So doing amniocentesis in the multiple pregnancy, just like monochorionic twins, we can go for one sac only. There is no doubt about it. Any kind of hetero thing, we are suspecting that any other patient has, any baby, one of the two babies have got an anomaly, then we may think of taking from the 2 sac, but it is not indicated usually, or 1 sac can do the thing. And another thing, in the DADC twins, we have to go for a 2-needle approach. 2-needle approach is what? We have to go through the 2 sites and 2 needle different to take the amniocentesis sample, amniotic fluid sample. So there is no doubt about it. All things, whatever I have told, it is from the ISWO guideline only. Then BGOG guidelines, they have explained, that is the green top guideline. So how to maintain a good practice in the amniocentesis, how to go for these things, maintain competency by telling our juniors, like whenever we are going certify, we have to give minimum 20 amniocentesis or chorionic villi biopsy procedures annually they should have done. So that communication skill training, the all kind of counseling training, many kind of procedures by doing your hands, the skill development, that happens very good, as well as that it is beneficial to the patients. So ISWAG practice guideline is there, invasive procedure for prenatal. We should go for this. So we have got a study, on a very large study. I have presented in this 9th Asia Pacific Conference of Fetal Therapy. That was about amniocentesis and chorionic villi biopsy. How far benefit outweigh the risks? Then only we see when to offer, basically. That is very important. The retrospective study we have conducted from 2020 to 2023 August. Basically, it has been conducted in my institution, Krishnaya, as well as SSKM Medical College. In this study, we have got a cohort analysis of who underwent amniocentesis and chorionic villi biopsy, and we have seen all kinds of things, but we have excluded many kind of IVF pregnancies and miscarriages. They have got a previous IVF pregnancy with miscarriages, because we couldn't do the amniocentesis on those cases after the things, and we have got underwent the reductions. So patient records we have went through, and we did the study with almost 1,069 patients. Various indications of chorionic villi biopsy. Our aim was to analyze the indications for late amniocentesis, the complications associated with the procedure, as well as the genetic diagnosis obtained. So late amniocentesis we did in 12 cases. That is mostly due to the late referrals. Actually, that was my scenario. Then 10 late onset anomalies like hydrocephalus, hydrocephalus, autosomal dominant polycystic kidney disease, skeletal dysplasia, and Noonan syndrome as well. Complications were spotting for vagina, first day leaking, abortions, retroplacental bleed, and fever. And that was least among the 1,069 patients. So 2 late amniocentesis complicated to preterm labor. And those were with the already complications, basically. So indications of CVS, chorionic villi biopsy, was thalassemia in 257 patients. Among the 304 patients we have done, Pompe disease, 1 patient, mucopolysaccharides type 2, 1 patients, spinal muscular atrophy, that was 23 patients, and Duchenne's muscular dystrophy, it is the 22 patients. Indications of amniocentesis were thalassemia. It is a very pro zone for the thalassemia. So every other couple come with the thalassemia carrier. So, but in thalassemia, we have to know which patient should go for the where to offer the thalassemia, basically. That is very important. If both are beta thalassemia carrier, then we are going for the test, because in the 25% chance of the thalassemia major, and though 25% chance of the minor and 50% chance of the normal. But in case of other kind of things, thalassemia capital E, or with the beta thalassemia, then that can create a E beta thalassemia disease. So we must go for a prenatal diagnosis. But if it is a capital E and capital E only, then we may not go, because they may not going to, that major is not going to happen very frequently with the blood transfusion requirement. But many times they go for the 10% in cases, they may go for the blood transfusion required. So it is very important to counsel those parents properly, whether they are ready to get that 10% risk while having the pregnancy, or any kind of accidents they are suffering, but any kind of other kind of burden things they are suffering. At that moment of time, they may require the blood transfusion. So we may have to counsel them very efficiently, so that they may not blame later why my prenatal diagnosis has not been done. So after the prenatal diagnosis, if you are getting minor, or you are getting some other kind of things where you should not have done, but after the parent pressurized you have done, we must have a hematologist with us to counsel the patient how they should go through this baby in adulthood as well as the childhood. This is the way. Then many kinds of multiple congenital abnormalities, almost 285 cases we got. High risk of prenatal screening, it is almost 162. And skeletal dysplasia, 15 cases, recurrent polyhydramnios, 10 cases. In one case of recurrent polyhydramnios, that patient has suffered with 8 times of pregnancy, and that baby used to die at around 8 months intrauterine. But the main complaint was only polyhydramnios. The baby used to be very anatomically normal. So at that moment of time, we have to suspect many kind of things. So we have went for the amniocentesis, and we got the result with positive result, whole exome sequencing for glycogen storage disorder, almost in 2 cases. So those are the things, like Barrett syndrome can happen, sodium channelopathy can happen, so many other things can happen, Noonan syndrome can happen. Without any kind of anatomical much problem, the baby can have the polyhydramnios, and the baby can go to the intrauterine death. So that we have to make up in our mind, because polyhydramnios we should consider as a greatest abnormality to go for invasive. Then recurrent intrauterine deaths, that is also very important, we need to realize. Recurrent microtia, one of the case I will show, and recurrent IUGR, intrauterine growth restrictions, because that is very important to rule out. If it is recurrent IUGR is happening with that patient, what are the other causes that is causing? Many kind of syndromic approach where we may not find many kind of much major finding, and that can go to the thing. So genetic diagnosis, we get positive in the whole exome sequencing 59. Chromosomal microarray, almost 34 cases. Fish in 4 cases because of the rapid things. Otherwise, I don't prefer the fish, because fish doesn't give you that kind of arena that chromosomal microarray gives. So that is why it is very important. And MLPA, we have went for the cases like spinal muscular atrophy, Duchenne's muscular atrophy, dystrophy, and other kind of certain kind of glycogen storage disease. That is very important to realize, because MLPA is differing for the CMA for much reasons, because CMA is going for a very small kind of deletions and duplications they can catch, but if it is very large, then MLPA is preferred. So that's why clinical genesis is also very important. Maybe we are offering the test, but we have to have those prerequisites with us. That is very important. If at all we are not availing with the clinical genetics, we have to read a lot what the disease pathology, what kind of genetic mutations they can be associated, what kind of chromosomal aberrations they can associate. So after delineating all the things, we have to decide the test, which genetic test, because amniocentesis may not be very important. More important is about the what kind of genetic test we are testing. That is most important. That is the main fetal medicine factor actually. So this is one of the tests we have done, like what kind of whole exome sequencing we have analyzed in the 32 cases at that moment of time. And we have explained in the whole exome sequence, this is the mucopolysaccharidosis baby. And the next baby also came out to be positive. So she has to abort that case actually. That was really pathetic about her. And this baby is right now living and talking very nicely actually. That is quite good. But we can see the skull changes as well as the hepatomegaly and many kind of splenomegaly that has already happened to this baby. So the survival rate is very less right now. So this is a case of a recurrent microtia. The daughter is also suffering with the microtia with the sensory neural deafness. The brother is also suffering with the microtia with the sensory neural deafness. So they had come to our clinic to diagnose what is happening, madam, why it is happening. So we went through the pedigree analysis. There was no history. It was only intrauterine death with the pedigree of the second generation. Then we went for actually with this baby, it was 16 weeks. I went for all the ultrasonography and all, but at the 16 weeks, it's really difficult to go for the anatomy of the ear. Even if I'm going to do the diagnosing the anatomy of the ear, at that moment of time, it will be looking normal, because to establish the diagnosis of microtia, we should go for at least 28-week scan, so that the ear, pinna, tragus, everything has to be developed properly. So, but that will be really difficult. So we have to take the decision before that actually. So we went for the whole exome sequencing of this index baby, and it comes out to be the positive with the facial paresis, hereditary congenital diseases. That then we went for the other things. That was a I'm showing this was a likely pathogenic. Basically 2 mutations came out to be positive, but this facial paresis, hereditary congenital things, that comes out to be likely pathogenic. So we went for the HOXB1 genetic things while doing the chorionic villi biopsy. So amniotic fluid we did amniocentesis, and that has come to be positive. So we had to go for termination of the pregnancy. So naturally we are referring those cases, offering to those patients who are in a dilemma, very much dilemma, whether my baby is going to suffer, whether I am going to terminate or I am to keep, even the dilemma of the patient as well as the clinician. So we are solving it by doing an invasive. So this is a case of arthrogryposis, Perthes disease. It was also with the genetic positive actually. So it has come at around almost 18 to 20 weeks. So we saw the hands were flexed with the things, and the thing baby was sitting like a Buddha actually. So we went for the whole 3D and all things. Other images are also there, and we went for the whole exam sequencing, and it comes out to be positive with the arthrogryposis. So these are the quite indications. These are the like prominent indications where we can offer actually when we are seeing and we are diagnosing the baby is not moving at all the joint contractures are not moving, everything is contracted. So those things we can offer actually. And this was a case of quite a polyhydranous. Many kind of babies where the babies are very sick basically. They were not cerebrally active. So naturally other functions are not very much active. So naturally they are not taking the liquor or drinking the liquor, or they are not urinating either. And so naturally there will be a polyhydramnios. So these things happen. Later these babies actually die with the thing. So there is a case of Noonan syndrome. This patient had come to us at around 25 weeks, and we did the scan. We could find out these kind of things basically. We could find out totally hydrops. There was a nickel fold was very much increased, and we could find out a small kind of pulmonary artery with the 3 vessel trachea with the reversal flow. So, but we may not, we couldn't think that it was a pulmonary stenosis at that moment of time. We just kept the images, and I did the amniocentesis, and we sent for the torch PCR as well as the CMA, but unfortunately they come out to be all negative. And at the 28 weeks obstetrician again referred, the baby is already intrauterine death has happened. So if you're thinking, if I'm thinking that intrauterine death has happened, so we have to go for the next test actually, that is the whole exome sequencing. So went for the whole exome sequencing, and it came out to be Noonan syndrome positive. So this is the way the amniocentesis is helping for the genetic testing, delineating out. But not only the invasive test, it's about the other things also. That is very important to realize. Then another diagnosis we have done, that is about the osteogenesis imperfecta type 8. It is almost very rare case in the world. And that has been diagnosed at around 18 weeks. After seeing all these things, taking the pedigree analysis, considering to the all findings in the X-ray as well as the ultrasound, we went for the amniocentesis, and that comes out to be osteogenesis imperfecta type 8. And then in the next pregnancy, after doing this index case, she has got a second pregnancy also. But it was luckily, it was out of this genetic mutation. There was no genetic mutant positive, and she is carrying the pregnancy right now with a normal pregnancy. So in that way, the amniocentesis, all the invasive are helping us out, basically deciding. So this is a case of achondrogenesis type 1A. So these are the cases, we have got a very, very rare cases where the things have happened. So if we are considering the invasives, many a times we should not consider the invasive. Where not to do is more important, because it is the safety of the patient, safety of the baby and everything. So we have to calculate our things very much. So if I'm going for a choice of a amniocentesis or NIPT, so if I'm going for an isolated soft marker, it is by the Society of Maternal Fetal Medicine Consult Series. It is echogenic intracardiac foci, echogenic bowel. This all have likelihood ratio is very less, almost 1 to 2%. But if I'm finding choroid plexus cyst, single umbilical artery, urinary tract dilatation, as well as certain bone, but this 2% is going to almost like 2, 2, 2. So it is almost 8% likelihood ratio. So naturally, when there is 8% likelihood ratio, it is the more increased high risk. So there we may consider the invasive test, but not in the isolated marker. That is what this Society of Maternal Fetal Medicine Consult Series, they beautifully explained. The soft marker has got a, the most important thing we have to realize, it has got a euploid association as well as aneuploid association. If we'll consider the echogenic intracardiac foci, it has got a euploid association almost 12%. That is so, but aneuploid association is almost 2 to 3%. So we have to consider those things. That is very important. Whenever we are considering something soft marker to be deciding for the invasive, we have to consider the euploid association as well as even the nasal bone has got euploid association. Those things we need to consider. So that's why the cell-free DNA has been applicated from the beginning, like almost like down the lane almost 5 to 6 years, and it is a very good test actually. I should tell, cell-free DNA should be applied in many kind of cases where we are thinking that it may not be a genetic mutation. That is very important to realize. So the decision for the all these things, ultrasound, soft markers, double marker screening on all these things, aneuploid screening, what we are doing, all these amalgamating, even the patient history are going to deciding factor for your offering for the invasive. That is very important. Reliability of the NIPT test is also there. Many kinds of things we have to think contradictorily actually. If it is a mosaicism, if it is a low fetal fraction or maternal chromosome abortions are there, they are going to give you a false positive report also many a times. So that is why in those cases, or a vanishing twin, we should go for a NIPT in a very later thing. So those things we have to consider even if we are thinking blindly about the NIPT. Nothing is about blind. It is not blind about the invasive or blind about the NIPT, because ultrasound is a very important thing. Many a time the referring persons who are sending actually doctors, they are doing NIPT at their level. If they're thinking that double marker is very high risk, but many a times we need to think there may be some evolving anomalies are happening. That's why this double marker is showing like this. So NIPT is not going to solve that problem actually. So we have faced those kind of cases like single ventricle and single atrium. We found it around 16 weeks, but the NIPT is showing low risk. So naturally, whenever there is a frank anomaly, it is we are showing in the ultrasound, invasive is the golden rule that we need to understand. So for deciding NIPT or amnio, it is the ultrasound. We have to go for a phenotypical correlation in a very good way, in a very good expert hand with all kind of images, with all kind of clips keeping, so that it can be beneficial for the later things. That is very important. So screening of trisomy, that has been explained by Kipros in the Fetal Medicine Foundation, that is combined screening at 11 to 13 weeks, combining the age, fetal NT, fetal serum, beta IgG, PAPA, and everything. And we are calculating with the ductus venosus as well as PI as well as tricuspid registration. So nowadays, if we are calculating through the Astrea software, the risk is calculated in a much nicer way. Even the ultrasound at the level with a good software is calculating in a much better way, the risk actually, aneuploidy risk. So if it is a high risk, if it is more than 1:10, so we are going for the invasive test. But in our country, for the many kind of setup, we can go for the 1:50 or 1:100 risk also. Intermediate risk, it's the cell-free DNA test. If it is positive, then we are going for the invasive test. But if it is negative, then we are
gentle reminder, ma'am.
Yeah, it is time.
Dr.
I'm finishing
Yes,
only. It is finishing
next
only.
Speaker is waiting. She has to go for another.
So take-home points are, within the context of modern genetic technologies, late amniocentesis is a reasonable procedure, while late ultrasound findings are also should be identified. That is very important to realize actually. The following reasons support is to be regarded as a quick and helpful tool to help pregnant women after 24 weeks of gestational weeks. Firstly, the patient can gain their genetic result in a median of 10 working days. That we should actually think of. Enough time would be provided them to take the decision for the pregnancy. Secondly, the diagnostic yield of modern genetic technologies, that has to be actually beneficial to us, and we should utilize it in a proper intelligent way. In cases of normal CMA, we should go for a whole exam, because it is one of the boon that is upcoming, and many things were diagnosed where the CMA is negative. So we can think of in that way. Thank you so much.
Thank you, Dr. Devasmita, for this extensive indication for amniocentesis on talking of many single gene disorders. As I said, offering the patient the decision to terminate or continue the pregnancy. I think fantastic talk. Thank you very much. I think due to paucity of time, we go on to the next topic. Dr. Chitra wants to add something. Dr. Tamilchelli.
Thank you.
Thank you, ma'am.
Yeah. That was good.
Thank you so much, ma'am. Thank you. Should I answer my slide?
I think I'll take the privilege of introducing Bela Bhatt. She is an obs-gynae and fetal medicine consultant from Rainbow Women Hospital, Andheri, Mumbai, and has been working as a fetal medicine consultant there for years. And she has an FMF certified sonologist for fetal abnormalities and sonologist for nuchal scan. She is a life member of SFM.
Okay, that's enough. I think let's go to the topic.
Yes. Let's start with and hear more about the commonly detected anomalies and its prognostication. Thank you. And we are looking forward for your talk, Bela. Thank you
so much, ma'am, for those kind words of
introduction.
Yeah. Good evening, Dr. Devasmita. That was a wonderful talk. Yeah. In fact, all the talks were wonderful. And thank you so much, Dr. Malathi, TNFOG, Dr. Sampath Kumari, and the entire team for giving me this opportunity to be part of this wonderful webinar. Now, without much ado, I think I'll go for the talk which has been assigned to me, that is commonly detected anomalies and its prognostication. So, basically, as soon as we have already, these are various references, and I know we all use the ECOG and the FMF and many studies as far as counseling for common anomalies is concerned. The minute we detect a structural anomaly on 18 to 22 week scan, we are talking about second trimester anomaly scan, it's extremely important for the sonologist to kind of come to a conclusion as to what kind of anomaly it is, and then explain it to the patient in a way that the patient understands. Because the minute you tell that something is wrong in the baby, there will be a lot of confusion in the mind of the patient. Now, counseling is an art, we all know, of transforming correct scientific information into simple language, which is understandable by the layman, which will be help them take correct decision. Now, they will not understand any scientific language or terminologies. So you have to put it in a simple way. So yes, though it's an art, it's not just an art, because the sonologist who is doing it, so obstetrician who is managing the patient should have the knowledge about the condition which is diagnosed, should know the natural course of that condition and the treatment available for it, if at all required, involvement of other specialists as per the anomaly detected, and then let patient take decision based on their financial condition, affordability, social viewpoint, ethical and religious viewpoints. Now, whenever we are doing any second trimester anomaly scan, I'm sure everyone who's doing will agree with this, that every patient who walks in for a second trimester anomaly scan walks in with a precondition in mind that my baby is going to be fine, all is well, and all is going to be well. So because everybody wants a healthy, normal baby without any defect, right? They come in smiling because they just want to have a look at their normal baby. But we know as a sonologist that we are doing a very, very responsible job, right? And our words matter a lot. So what we need to tell is, at the beginning, let us have a close look at the structures of the fetus, and let's discuss at the end how your baby is. And even at the end of your structure anomaly scan, if you are sure that nothing looks abnormal as of now in this scan, we need to counsel to the patient that 90% of structure anomalies can be ruled out at this juncture, but 100% is always at birth. Why? Because there are certain evolving anomalies at 6, 7, 8 months, which we can't see now. Secondly, not everything is visible now. There are a lot of limitations. We all know about those limitations, the maternal obesity, the fetal position, the previous scars. So many things are there, liker amount. So it's not practically possible to see everything with the based hand, with the base machine also. Some of the anomalies may be missed. So never reassure the patient, yes, your baby is 100% fine. Always tell it's 90%, which can be humanly detected. Now, these are general principles first I'm talking about. Then we'll go to the individual anomalies and how to counsel the common anomalies. So if there is any anomaly, we always, as the previous speakers have emphasized properly, that history and first trimester screening is always taken into account. A detailed scan to look for other structure anomalies or any soft marker, because it will change the overall picture. Then we try and find out the cause. We also have a look at the growth centiles and mean uterine artery PI, because with the normal Dopplers, if the placental Dopplers are normal and there is early fetal growth restriction, again, that becomes one anomaly. It adds to the cause as the possible cause of chromosomal anomaly. We'll see in one of the cases, right? So what we try to do is we try to look at the whole picture and not just a structural anomaly, because we have to reach to a conclusion and we have to manage this case. We try and, if wherever necessary, to rule out the genetic cause, TORCH. We look at the markers for chromosomal anomaly, for the TORCH infection. And then at the end, it's a combined counseling by the sonologist, the obstetrician, the specialist of, if a particular system is involved, geneticist, and then the patient as well as her family. Last but not the least, in the general principle, even if it's a lethal anomaly or there's a poor prognosis at the end, and even if they decide to terminate, remember antenatal sampling, as Dr. Debosmita has emphasized, taking amniotic fluid and do a genetic testing, whichever is necessary. And if the patient is not ready for the testing at that juncture, at least a DNA storage, which is just costing 2,000, 2,500 is a must, because then you'll be able to not only find out the cause for this particular structure anomaly, but you'll be able to prognosticate whether there are any chances of recurrence in the next pregnancy, and that is going to go a long way in next pregnancy. So these are some of the common anomalies which I'm going to show, and we are going to talk about the prognostication about the same. So one of the commonest anomalies is neural tube defect. We all know various types of neural tube defect: open, closed, meningocele. This was a open spinal defect with brain changes, as you can see with the lemon sign and the banana sign. I'm not going to details of it, but we are going to talk about the counseling, how to go about counseling in neural tube defect. So there are two types of neural tube defect: open neural tube defect and closed neural tube defect. So as I said, first thing we need to ask a question as to what can it lead to, this particular neural tube defect. What is it going to lead to? So it can lead to various brain changes. It can have, by the effect on the spine, it can have effect on the lower limb movements, bladder and bowel control. So we have to look at the level of neural tube defect. We know the higher the level of neural tube defect, poorer is the prognosis. If there are brain changes, poorer is the prognosis. Lower limb movements, if they are affected, bladder, bowel, which is affected, then it is going to be a poorer prognosis, right? In general, open neural tube defect will have a poorer prognosis as compared to closed neural tube defect. Now, what do we mean by brain changes? So as we know that in Arnold-Chiari malformation, we see that there is because there is open neural tube defect, because of draining of CSF, there is pulling down of the hindbrain, the cerebellum, which is going to cause a banana sign of the cerebellum, and there is scalloping of the frontal bone leading to lemon sign. So these changes are going to tell you that the prognosis is obviously going to be a poorer one, right? Now, first question we have addressed. The second question is, what causes this open neural tube defect? So we know in 90% cases the cause is folic acid deficiency, but in 10% it can be because of the anti-epileptic drug if the mother is on, gestational diabetes, and of course in a recurrent case there can be some chromosomal or genetic anomaly. So as again each one of us keeps stressing the importance of history taking. You should be knowing what all medication patient is taken, whether the patient is diabetic or not, whether the sugars have been done in this particular patient. Sometimes the patient has been sent to the for anomaly scan, but the sugars or the screening test with PG2BS 75 grams glucose test has not been done. So that all has to be looked at. The papers have to be checked and rule out the causes. Okay, so that's what we try to find out the cause of it, and then we should try and find out what is the prognosis. So in open neural tube defect, these are studies which have proved that 5 years mortality rate is 35%, and the surviving infants usually have paralysis in the lower limbs and double incontinence. And higher the level, higher the chances of all these complications. Recurrence in case of open neural tube defect is if in affected parents or one sibling is 5%. If two affected siblings, it's 10%. So all these information we should know before we counsel the patient, because we'll have to tell about that. Now, what about closed neural tube defect, where it is not communicating with the amniotic cavity? Again, the level of neural tube defect is important. Some of them may still have brain changes if it's a big meningocele or meningomyelocele. We look at everything, lower limb movements, bladder emptying, etc. But if there is no brain changes on ultrasound, good lower limb movements, generally the outcome is good. But bowel bladder function can't be assured intrauterine. So that again has to be told to the parents. So there can be varying degrees of bladder bowel control after birth of the child. So having given this information, let them take decision about whether to continue or whatever. But most of these closed neural tube defect, they are at least ambulatory. That's a positive thing which has to be communicated to the parents. Now, counseling doesn't just include advice about this pregnancy, but also tells you about the planning for next pregnancy. It's a severe defect. If the patient wants to terminate, then what is most important, it is to prevent in the next pregnancy. What is to be done? High-risk patients who have had neural tube defect in this pregnancy should be offered 5 milligram of not just folic acid, but also vitamin B12 at least 3 months pre-pregnancy and till 3rd month and throughout the gestation. Whereas low-risk patients who do not have such history can be given just 400 microgram of folic acid with vitamin B12, because it is said that when you combine both folic acid and vitamin B12, you can prevent almost to the tune of 90%. Whereas if you just give only folic acid, you can prevent to the tune of 75 to 80%. So it's better to combine these two and give it in this high-risk patient. This image I've just put, this is not at the 2nd trimester anomaly scan. This was picked up at our center at 12 weeks of pregnancy. This was a defect in the occipital bone with developing encephalocele. But we know it's a severe anomaly which was counseled to the patient terminated. But what is more important is we did the genetic testing and of the fetus because they were not ready for antenatal testing, but the genetic testing turned out to be normal. But the patient was given a 6 months course of folic acid with vitamin B12 pre-pregnancy. Also, they took it for 3 months. She conceived again. She continued with me throughout the pregnancy, and in the 2nd pregnancy at term, she delivered a normal baby. So that's the importance of following up before the next pregnancy and improving the outcome in the next pregnancy as well. So pause to ponder in neural tube defect is that both folic acid and B12, 5 milligram folic acid and B12, 3 months before next pregnancy and 2 months after conception reduce the risk of neural tube defect. And of course, if there is a recurrent neural tube defect, genetic testing is a must, because there can be, we know that genetics is evolving like anything. Many of the genetic defects, problems we were not knowing before, many of the mutations we didn't know before are now being picked up. So at least as DNA storage is a good practice, because in future we may find something after 6 months or 1 year when the parents are ready, we may find some abnormality, genetic abnormality. This was a case, though the soft markers have been already discussed, I would like to emphasize here that this was a case where there was unossified nasal bone, but there was also 2 echogenic intracardiac focuses. And not only that, as I said, we also have a look at the growth. So once the dating is confirmed, you look at the growth, and look at the growth here, it's a 3rd centile. The uterine mean uterine artery PI was normal, so placenta was not the cause. This is an early fetal growth restriction with an ossified nasal bone, with the echogenic intracardiac focus. And obviously, the patient was counseled for high chances for some chromosomal cause. Amniocentesis was done, and it turned out to be trisomy 21. So as we say, we look at the whole picture, the history, the 1st trimester screening, all the structure markers, all the soft markers, and then counsel the patient and advise about what test is to be done. Another case which in the 2nd trimester anomaly scan, it showed it's a very, I hope it was a dialogue and we could interact. It's very, very obvious, a double bubble sign of duodenal atresia. There was no other structure anomaly or markers present, but patient was explained that this is one of the markers for trisomy 21. Amniocentesis was done. Again, this turned out to be trisomy 21. So that's the importance of communicating about the structure anomaly and confirming it with a genetic invasive tests. Now, as far as cardiac cases are concerned, number one, remember, whenever we are not sure of a structural anomaly in cardiac anomaly, it's better to refer to a expert, because as is previous speakers have mentioned, there's a lot of learning curve as far as diagnosing cardiac anomalies is concerned. So I'm going to just quickly show 3 cases of, this was a tetralogy fellow where there was, you can see the overriding aorta, and along with that, you can see that there was reversal of flow in the ductal arch. This was another case. Just quickly 3 cases, and then we'll discuss how to prognosticate cardiac cases. This is the case where you can very well see, if you know about the 4-chamber view, there's something wrong with the left side of the heart. When you put on the Doppler, you see the flow only across the tricuspid and not across the mitral valve, and we know for sure that this is hypoplastic left heart syndrome. Another case where there was a muscular VSD, no other anomaly which was picked up in this particular case. Now, just put this 3 case, and then we are going to try and see as to how to counsel when there is a cardiac anomaly. Now, again, we must know about the natural history of each and every condition and what is the available treatment. Again, I would like to say here that these days, there are a lot of good pediatric cardiosurgeons. So more and more conditions are treatable now. But then again, this financial aspect and whether the patient will be able to go to that center and get it operated and all also comes into the picture. So this is a beautiful study which has shown some of the prognosticating markers as far as cardiac anomaly is concerned. So it tells that adult survival after correction is more than 95% if it is isolated VSD, PDA, ASPS or TAPVC. It is 70 to 80% if it is isolated TOF, TGA, COA and AVSD. I'm not going to into details of it. 50 to 60% that the prognosis becomes poorer and poorer if there is a single ventricle which is functioning and there's a complex CHD, and if it is less than 10% survival if it is hypoplastic left heart syndrome, right? So these are some of the prognosticating markers. And which are the single ventricle defects? When there is tricuspid atresia, hypoplastic left heart, we saw here the mitral valve atresia, single left ventricle, double inlet left ventricle, etc., etc. I'm not going to complete the list. So overall, if you have to look at it, when you look at your 4-chamber view and your the outflow tracks, the outcome is good if the 4-chamber, all the 4-chamber size and function is normal, but the outcome is bad if either of the ventricle, whether the left or right, is hypoplastic. As far as the outflow, the left and right are concerned, the outcome is good if there is no atresia of either of it, but the outcome is bad if either the pulmonary artery or aorta are attracted. Out of the aorta and pulmonary, the outcome is better if the pulmonary artery is small, but it is bad if aorta is small. Prognosis, if it's a progressive lesion, you are following up and it's progressive, there is cardiomegaly and cardiac failure, then obviously the prognosis is going to be bad. It's a duct dependent, it's going to be bad prognosis. Extra cardiac malformations are there. Chances of chromosomal genetic cause is high. The prognosis is going to be poorer. Okay. Now, as far as isolated muscular VSD is concerned, we must know that if the diameter is less than or equal to 3, no other structural cardiac anomaly, no other structural anomaly in the fetus, no other soft marker, then the spontaneous closure either till term or in the first postnatal year is very, very common. So prognosis is good. Now, what happens about the prognosis in our 3 cases? Let's look at this. In this case of tetralogy of Fallot, there was a cardiomegaly, obvious cardiomegaly. You can see it is occupying almost half of the thorax. There is pulmonary stenosis. There is reversal of flow in ductus arteriosus. So obviously the prognosis is poor here. In this, again, we know it's a single ventricle which is functioning. There's no flow across the mitral valve. The left ventricle is not developed. The prognosis is going to be poorer. And isolated muscular VSD, we know that there's no other structure anomaly. Both great arteries are of good caliber. All 4 chambers functions are normal. The prognosis is going to be good. And this was followed up postnatally. And this baby must be almost 3 years old now and is doing well. It healed on its own. So counseling involves a prognostication based on various factors. The need for genetic test wherever necessary, let the family take decision and then decide whether to continue pregnancy. And wherever necessary, where you feel that a cardiac, whenever there is a cardiac anomaly, we always send the patient to a pediatric cardiosurgeon because they are in a better position to counsel about the prognosticating, how many surgeries will be required, what will be the financial burden, and how the baby will do in the postnatal period. So it's always a teamwork of sonologists, obstetrician, fetal medicine consultant, the geneticist, and the specialist who will then talk to the family and help them take decision. One very, very important thing in cardiac defect, not every congenital heart disease needs termination, right? Somebody also mentioned that, Dr. I think Jemmy mentioned that if echogenic cardiac focus is still people are terminating for that. Remember, it's not a cardiac defect. right? Isolated echogenic cardiac focus without any structure anomaly in the heart and other soft markers is absolutely not going to increase even the chance of trisomy 21. So remember these things, not only that, but if you are not sure of diagnosis of any structure, you feel that this heart doesn't look normal, better to refer to an expert and let them make the diagnosis, and let's help the patient better by referring to a good sonologist as well as the pediatric cardiosurgeon. So first aim of ours is primum non nocere. First, do no harm. The minute you see something abnormal and you tell the patient there is some defect in the heart, they'll say, I want to terminate. Please don't do that. Say, I feel that this needs a second opinion. I'll refer you to somebody where we can have a better idea about the heart of the baby. That's the way to go about the cardiac cases. This is a case of congenital diaphragmatic hernia. You can see here very well in the sagittal as well as axial section. This is the four-chamber view of the thorax. You can see the heart is pushed to right by the stomach, the liver, and some bowel loops. And here again, prognostication depends on many things. We have to rule out other anomalies. Fetal echo has to be done to rule out cardiac anomalies, and genetic test has to be done to rule out any kind of chromosomal cause. We have perinatology.com. Any obstetrician, any sonologist can go online, put your values into this. You have to take a good contralateral lung measurements and put it in this, and you will have the prognostication in hand. What is most important out of all the ratios, there are 3-4 ratios here, but even if you look at the observed upon expected lung head ratios based on the measurements that you feed in that perinatology calculator, you will get your prognostication and factors. And here you can see that if the observed upon expected lung head ratio is more than 45%, overall prognosis is good in this diaphragmatic hernia. If it is less than 25%, then the chances, the prognosis is bad. Not only that, if there is liver herniation, the prognosis is going to be poorer as compared to no liver herniation. So there are many other ratios, but I'm not going to details of it for the want of time. These two things also can help you a lot to kind of prognosticate. And remember one thing, earlier the herniation, it may happen so that there is a defect in the diaphragm, but the herniation of stomach may happen at 20 weeks, 28 weeks, 32 weeks, 36 weeks. So later in the gestation is the herniation, better is the prognosis. Earlier in the pregnancy, the herniation, poorer is the prognosis. Okay, so in my case, it was at almost 22 weeks, and so the prognosis was poorer based on all these factors, right? Which has to be counseled with the patient. So as I keep on repeating, it's always counseling has to be a multidisciplinary approach by obstetrician, fetal medicine expert, neonatologist, pediatric surgeon, geneticist, and talk to the patient. I'm just concluding quickly. So this is a case of congenital talipes equinovarus. Now, this is again a very common anomaly, and obstetricians are always into dilemma as to how to counsel the patient. Now, remember one thing, whenever there's congenital, whenever you are looking at your tibia, you should not be able to see the foot. If you see both of them together, then it tells you that it's a CTEV. So now, as I told, once an anomaly, you have to rule out any other anomaly. We are talking about isolated anomalies here. So we rule out other anomalies. There is always a possibility of chromosomal cause. So we offer invasive testing, amniocentesis, and then if everything is ruled out, no structure anomaly, the amniocentesis and genetic test is normal, then antenatal ortho opinion has to be sought so that patient gets idea as to how this is going to be corrected postnatally by a surgery or by a shoes or by in what manner. So this case I'm showing here because this particular baby had a unilateral CTEV, and a patient was, the genetic testing was normal, patient had gone antenatal to an orthopedician who told that we can correct this postnatally with the help of some of the physiotherapy and shoes, and this particular baby was benefited by that, and the this is at the age of 1.5 years, where the baby's, the leg foot orientation was completely normal with the help of physiotherapy and shoes. So that's the importance of counseling the patient and doing a multidisciplinary counseling. Another case, consanguineous marriage, where there was bilateral CTV. If you can see this in this video clip, there's bilateral CTV, as you can see in both the legs. And not only that, there was also mild pilectasis. Now, when there are this bilateral with mild pilectasis, again, there's a higher chance of some chromosomal or genetic test. Patient was counseled about genetic testing. Patient went for amniocentesis, microarray was done, but luckily, it did not reveal any clinically significant copy number variation. But it's our duty to counsel, because there are chances of some genetic syndrome or some genetic defect in this particular baby. So isolated CTEV, we explain about the small possibility of genetic cause, do amniocentesis and genetic testing. If it is ruled out, generally the prognosis is good. Antenatal consultation with orthopedic surgeon can help them take decision, and the shoes or surgery with them, that they'll be able to walk well. So it's our role, because I've seen people with CTV also terminating. So it's our role here to intervene and counsel them well with the multidisciplinary approach, so that they do not terminate without getting counsel and understanding the problem. This was a case of lower urinary tract obstruction. Very, very obvious, the keyhole sign with proximal urethra dilated. We know for sure this is a bladder, because flanked by 2 umbilical arteries. And there was also, you can see the echogenic kidney because of nephropathy, which was caused. This was early on in the pregnancy, and you can hardly see any liquor. So whenever there's lower urinary tract obstruction, how do we counsel this patient? Again, a detailed ultrasound examination, amniocentesis, because in 10% cases, you may find some of the chromosomal problem. Poor prognostic signs are presence of bilateral multicystic or severely hydronephrotic kidneys or echogenic kidneys, and hydroamnios, as we could see in this case. These are all poor prognostic cases. If at all these factors are not there, the liquor is good, the kidneys look normal, we can follow them up. And in my one of the case, I had not this one, the other one, where patient which was diagnosed at 29 weeks, and then I followed her up till 34 weeks when there was anhydramnios, and then the patient was operated in a tertiary center where the pediatric surgeon was present, and post-natally the baby was operated. That baby is now 5 years old and doing very, very well. But not in this case, because this was at 20 weeks such an anhydramnios. So there's going to be pulmonary hypoplasia, which is the most important prognosticating factor in luto, because the anhydramnios is going to lead to pulmonary hypoplasia, which will kill the baby. So again, depends on how early is the manifestation as opposed to how late in case of lower urinary tract obstruction. And we have talked about what all to counsel to the patient. But again, remember, what to tell is important, but what not to tell is also equally important. So isolated unilateral renal agenesis, no other anomaly. Confirm that it's isolated, first of all. Rule out CNS, any other anomaly. And the other kidney looks normal. There's normal bladder, normal liquor. Prognosis is excellent. We all know sometimes in adulthood, when they go for scan, they know that there's only one kidney which is functioning very well. The patient has no complaints. So the prognosis is excellent. The patient will be under great stress. So it's our duty to tell that there's no need to terminate, because with one kidney also one can be alive. Isolated diastematomyelia, where there's a bony or fibrous spur in the middle of spine. Again, the patient will be frightened. What will happen to my baby? I have 2 cases wherein there was isolated diastematomyelia and no other meningocele, no myelocele, where the patient was counseled. Of course, I had sent the patient to the pediatric surgeon also antenatally, who counseled that there is no need to panic, we can follow up. And then postnatally, this baby has been followed up till 5 years, and the baby is walking well, no problem, no bladder ball problem. Prognosis is excellent. So here, What is important is to be non-directive. There are many patients who would want to continue in the fetus with an anomaly. We all know Down syndrome babies also parents want to continue. Anortia, the patient wants to continue. Anophthalmia, patient want to continue. So we shouldn't be directive to the patient. Just provide the information to the patient about the natural course of that particular anomaly. Do a multidisciplinary counseling and let the patient and the family take the decision at the end. Whatever words we utter should be chosen with care, for people will hear them and be influenced by them for good or ill. So that's our responsible job when we are counseling the patient for any anomaly. With this, I would conclude. Thank you so much for patient hearing. Thank you.
Thank you, Dr. Bela, for that excellent talk. Yes, as a obstetrician, it is very, very important that what we tell them carries everything in a long way for them as a parent. So we should know to counsel them well. Thank you very much.
Thank you.
Thank you, Malati, for giving me this
Fantastic.
opportunity to be with all of you this evening. Though I joined
Dr.
late,
Chitra
I regret for joining late. But then,
no problem. Dr. Chitra, our
excellent.
past president of Trichy ONG Society, a good friend of mine also. So I have all the liberty to tell her to come, or she always obliges. Thank you, Chitra. Thank you very much.
Wonderful,
thank you, Dr.
being
Bela. Fantastic talk. Beautiful images. Images were fantastic. Thank you so much. I think someone wants to, I would like to thank all the speakers, Dr. Debasmita, Dr. Bela, Dr. Deepti Jami, and the others. I think all of you did a wonderful job. Dr. Lalita also. I think we'll be awaiting the next webinar maybe on December 18th, the third Sunday. So thank you, speakers, for joining in. Thank you very much. Thank you. Thank you, Dr. Aditya, for your answers. Thank you.
Thank you for the opportunity, Dr. Malti, and it's a wonderful webinar. A great
Yeah, it's a wonderful
webinar.
webinar, actually. We are really pleased to be here, actually. Thank you so much.
Yeah.